My name is Danielle Ragib, and I am here today to support this next session on non-suicidal self-harm and injury reduction, um, which is session one of today's workshop. I will be moderating this session and the discussion, and we're going to take a closer look at our flow over the next 90 minutes together. So first, I'll share some framing and context for this session. Then we'll meet our speaker who will share a wonderful presentation with us, followed by an opportunity for our audience, which is you, to ask questions and engage in discussion. And I'm going to now bring in our wonderful presenter, Priscilla Ward, who is going to share with us her beautiful presentation and also facilitate conversation as well. So I'm going to now hand it off to Priscilla to introduce herself and get us going.
Hi, everybody. First, I want to say that I'm in deep gratitude that everybody that is here has shown up. This is, I think, a really, really precious opportunity for us to dialogue about a really important topic. A little bit of my background. I'm a licensed clinical social worker. I've worked in a variety of different settings, everything from community-based mental health to corrections to drug court. I've done every level of care, direct service, all the way up to program management and program development. So I've had quite a bit of exposure to different settings and different roles, and it's through that learning and that experience that I've really grown in my exposure to harm reduction and in learning to really integrate harm reduction into all of the work that I do. I think oftentimes we hear harm reduction and we think just of substance use disorders, but the reality is that harm reduction is a philosophy that we can apply across the board. So I'm hoping to be able to share some of that wisdom with you all today. I'm going to mention that my slide deck is pretty content heavy. And there's two reasons for that. One is there's a lot to cover, but two, I really want you to be present and listen and dialogue and interact. And so I don't want you to worry that there's something that is covered that you're not going to be able to come back to. So everybody has access to that slide deck. There's lots of info there for you. So please don't worry about that. The other thing is that I have invited Danielle to interrupt me throughout because I do want interaction and I do want dialogue. So please make sure that you're dropping those questions into the Q&A, and that'll allow us just a chance to make this a little bit more real for you as we go through it. This is a pretty heavy topic, and we recognize that it could be triggering, and so you have every right to take care of yourself. So please do so. If there's anything that we're talking about around non-suicidal self-injury, suicide in general, or things that are hard to hear, take a beat. It's okay for you to take a step back. You can turn off your camera, do what you need to do to take care of yourself. We trust that you know what you need, so please do so. As I'm jumping into this, there are some foundational things that I want you to keep in mind. I'm going to be doing a lot of that content heavy intervention, tangible types of things. We were set up beautifully by our keynotes to really lean into this philosophy. And now this is the stuff that's more information heavy. So with that, I don't want you to lose sight of a couple of things. First, a lot of what we're going to be hearing about is grounded in ancestral wisdom. We have developed these strategies around harm reduction, and a lot of this came out of the AIDS epidemic in the 80s and the drug war, and we've learned so much. But when we really lean in, Indigenous communities have been doing this forever, taking care of their people, embracing people as they are. And so I want you guys to keep that in mind as we're going through maybe a lot of things that come across as very Western based. The other thing that I want you to keep in mind as you hear all of this information is that we have to decide that we're going to care more about people's suffering. We're going to care more about people's well-being than we are about stopping a behavior. than we are about compliance and than we are about control. So super important. I think this goes hand in hand with what Maurice and Jen mentioned in terms of care, not control. So really keep that in mind. We're going to care more about people, their suffering, and their wellness. Another mind shift that I want you to consider here is that we have to redefine our view of success and joy, what our lives look like, what we choose our lives to look like, what we choose our joy, our success, our happiness to be, is going to look very different for everybody else. And that includes the communities that we serve. It should really be central to us that we are empowering people to create meaning and purpose in their lives in the way that they see, not necessarily in the way that we see for ourselves. I really want these things to transcend all of the content that's going to be reviewed, so I might come back to this stuff periodically. With that, what is non-suicidal self-injury? The biggest thing here is non-suicidal self-injury is essentially any type of harm to yourself that does not have suicidal intent. We often hear about cutting, burning, scratching, carving into the skin, head banging. I did see that there's a lot of attendees here today that work in school-based settings or work with youth-focused organizations. And so this is something that is very, very present in our young people. And so it can bring up a lot of feelings. It can bring up a lot of worries because the reality is that it is possible that this could lead to more dangerous behaviors. And it's also a reality that those who engage in NSSI have a higher risk of suicide without intervention. And so the concerns are real. I don't want to minimize or negate that, but it's really important to understand that when we're talking about non-suicidal self-injury, we're not equating that to somebody who is actively suicidal. And that is a mistake that folks often make because we get nervous. You know, a lot of things can be triggered in ourselves, but again, we just want to remember non-suicidal self-injury, there's not an intent to complete suicide. Why do people engage in NSSI? We've come a long way in understanding some of the different drivers for NSSI. And the reality is that this is multifaceted, just like everything else is in our world. There's not one thing, there is not one answer. Oftentimes things occur within the context of other mental health conditions. You know, somebody might have a mood disorder or a borderline personality disorder, something that we hear of often. Other times, people are trying to find a way to cope, manage, or express their emotional pain. There can be a desire to escape, but sometimes it's really just a desire to feel. And sometimes there's also external factors. There are things that happen outside of us that influence us. And so it could be, you know, significant conflicts, challenges in any relationship, really. Sometimes it is a cry for help. We hear that, but it's not always. There's so much depth here. And so what's really important is that we take time to understand what is a driver for each person, because there will not be a one size fits all. And there's not going to be just one explanation as to why this is happening. In the list on this slide, that fourth box at the bottom, there's one thing that I just want to highlight. One of those points is eliciting an interpersonal response, and the example there is in borderline personality disorder. And I think oftentimes in just mainstream media, or sometimes even in conversations with folks that don't have a lot of awareness or understanding, we hear that these types of behaviors, they're just, they're just attention seeking. And so while that could be true, the reality is that it's not always that simple. And so I really hope that you all are able to be just good proponents of educating folks to understanding, sure, maybe, but there's so much more, and there's so much more depth to what impacts somebody to get to this place. Really understanding that there's a deep suffering that's occurring, and that's the part that we want to connect to. Um, in true clinical fashion, there are plenty of ways and plenty of tools that we can use to assess and evaluate when we're working with clients to just help guide us honestly to better understand, ask the right questions. We're going to drop the links for these assessment tools in the chat. Um, really encourage you all to go through, and this could also just help to guide the way that you interface when you're trying to learn and gather more information when it comes to self-injury, especially if it's not a topic that you're super comfortable with. There are some questions that can be I guess a bit intimidating to ask folks, but I want to remind you that our goal is to connect and to understand and to meet people where they are. And so we have to be willing to ask those hard questions. We have to be willing to face our own discomfort in order to truly be able to learn. I'm going to give you just a few slides here that show you what these assessment tools look like. It could be something as simple as how often in the past month have you, and then, we give some options, had a thought, actually injured yourself, those types of things. All the way to like very, very specific types of monitoring in terms of like, what did you actually do? What part of your body did you harm? How long did you harm for? How long did you feel relief? What did it accomplish for you? So again, these are pretty extensive. There's one that is very long, but there is a short form. But I just encourage you all to take some time on your own to review those and just get comfortable with learning how to gather that information and understand it a bit. Some important things to consider when it comes to NSSI. So we know that the incidence of NSSI is much higher in young people when we compare that to adults. So we want to keep that in mind when those are the populations that we're serving. In addition to that, we know that females are significantly more impacted by NSSI. And so again, we just want to have eyes to see the things that are happening in the populations that we're serving. And the reality is that harm reduction is going to be one piece and one part of the process for folks, especially if they're dealing with underlying mental health conditions. And so we have to do both, and it's not either or. I really want to challenge the binary that we define things as either this or that, either good or bad. The integration of multiple approaches is what is impactful and most helpful for folks, because what works for one person isn't going to work for somebody else. We heard from our presenters earlier today about the need for all different levels of care depending on where we are at in our lives. Maybe somebody is in a place where maybe they really are going to benefit from something that's abstinence focused, but that's not going to be true for everybody. So we want to make sure that there's options and that we're addressing the underlying needs. Sometimes when we have these conversations, it can feel very doom and gloom. We're talking about the difficult things and the challenges, and we don't take enough time to pause and acknowledge that there's also protective factors. And protective factors are so important in supporting people and really facilitating transformation for folks. So community and interpersonal connections are so, so important. We are at a time where we are hearing a lot more about peer support and learning from lived experience and integrating that into practice. Those are huge, huge protective factors that we don't want to discount. Another aspect that we sometimes forget to talk about is prevention and early intervention. Now, I mentioned before that we know that young people and especially females are a higher risk. And so we want to have eyes to see those things so that we know where to look. We want to look across the board, right? But we also don't want to ignore when we know that there's communities that are at higher risk. And so making sure that we are taking time and just being very intentional with the work that we're doing. NSSI is really difficult, even for individuals who engage in the behavior to talk about. It's often not safe. They often feel judged. Uh, they are isolated. People make so many assumptions. So we have to recognize that there's a really significant impact when it comes to secrecy and shame. These are behaviors that people get so good at hiding because it's not safe to share. There's also a lot of dangers associated with stigma. I know that I have clients that I see that won't wear short sleeves, especially if they're going out to like a job interview, or they're going to be entering into a space where they don't know the people really well, because those are opportunities immediately for them to be noticed and be painted in a really negative light. Um, I also want to point out that harm reduction is absolutely aligned with a trauma-informed and person-centered lens. And so we need to bring that to the table for folks as we are having these conversations with them.
There's a question about whether eating disorders are also considered NSSIs.
So I would say that we need to go back and look at the intention of what's driving the behavior. And so it is possible that somebody's ED is connected to NSSI, but that is not always the case. I feel like EDs are a whole world in and of themselves, but one thing that I would say that there's sometimes some crossover is when people engage in NSSI, sometimes they're desperately looking for something that they can control. And when we're looking at ED, you can absolutely control what you put in your mouth. You can control what you consume. And so there is this overlap sometimes with this desperation, but I feel like EDs really deserve, honestly, like their complete own time in training and understanding, but there can be that overlap.
Thank you. And the other thing that came up in the chat was some pretty lively conversation around the meme of it being, anybody who's engaging in an SSI is attention seeking, and what does that mean, and how do we respond to that? And I thought it was actually lovely. Somebody said that they prefer the phrase attachment seeking rather than attention seeking, and I wondered if you wanted to just add a few more words to that conversation.
Absolutely. One of my standard responses when somebody just tries to label NSSI as attention seeking is, you know what, even if it is, imagine what somebody must be enduring that they're trying to get your attention in that way. That's their communication, and really shifting the lens into like, let's have some love and some empathy and some compassion. Let's forget about like, oh, this is just attention seeking, but gosh, like this person is telling you they need something from you. They need something from you. So if this is the way that they're telling you, let's listen. Let's listen in and forget about all of the other buzz. But I love that attachment seeking. Okay.
And then the
When we were
last thing,
talking, yes.
sorry, there's one last question is somebody's interested in knowing whether excessive tattooing could be considered an SSI.
It could be. So I actually have a client, if we think about harm reduction on a spectrum, I have a client who went from pretty like profound cutting, burning, and they made the transition to tattooing. And that's come, with its own ups and downs. But that has been a way to satiate that need and that drive for them. Okay, I'm going to continue here. So when we think about responding to NSSI, again, we want to have a multifaceted approach. First is safety planning. And I think one of the foundations of really effective safety planning is that we need to be willing to like educate our clients, educate the people that we're working with. Like, hey, like let's talk about how this impacts you. The good, the bad, and the ugly, all of it. Let's look at all of it, and let's look at how we can help keep you safer, how you can keep yourself safer. We also need to look at different treatment responses, because oftentimes we look at just reducing like the incidence of NSSI at all. We want abstinence. But really, we can look at frequency, we can look at recurrence, we can look at intensity. That client that I just mentioned, for him, shifting from cutting and burning to tattooing, that's progress. That is pretty significant progress for him. And so we need to have eyes to see that, and just be open to embracing what are the most effective strategies, and realizing that it's going to probably take some multiple approaches here. And when we're talking about mental health disorders, also ensuring that we're integrating that knowledge that we have to really help people move forward. If we're not identifying things that are underlying or impacting folks, we're dead in the water. It's really hard to make, progress. If somebody comes to you and they're like, I have a headache, and you're like, here, take some Advil. They can take the Advil all day long, but the moment they stop taking the Advil, their headache comes back, and we're not asking the questions like, when did you last eat? Like, how have you had water today? How's your sleep, right? Those types of things. And so we want to think about mental health disorders in that same way, make sure that we're integrating some of that underlying understanding into these approaches. Central to what we do when we respond to NSSI, I don't want to forget to say, is that we have to remain understanding and patient. We have to be able to build trust with the people that we're working with. Okay. Any other questions here?
Yeah, there are a couple questions in the Q&A box. One is around how do we assure that care continues for everyone? So like you said earlier, Priscilla, young folk are really the largest population impacted by NSSI, and we see it a lot. It's more prevalent, but some adults also experience and engage in NSSI, and it carries over from, youth into adulthood, and they often feel like there's no resources for adults. And so the question was, how do we assure care continues for everyone?
Yeah, I think that's a great question. Honestly, and this might not be the greatest answer, but I think conversations like this, symposiums like today, I honestly was floored to see the number of registrants that showed up today. But we have to ensure that there's a transfer of knowledge, that when people come and learn this information and gather this knowledge, that you go back to the systems that you work within, that you go back to the organizations that you work in, that you go back to your colleagues and you share. There needs to be some profound systemic change. And some of us can't permeate all of those systems, but some of you work in these systems. And so being advocates and ensuring that there's that transfer of knowledge is really, really critical. That may not be the greatest answer, but I think it's something that's really empowering and a great reminder for you all that are here today.
Yeah, thank you. And then we have another one. Someone is saying that they were recently introduced to the TIP technique, the TIPP. Do you feel this is harm reduction?
Can you tell me what the acronym is for TIP?
I actually am not sure. So I'm going to invite the person who asked the question to tell us what TIP is. Temperature, intense exercise, paced breathing, and paired muscle relaxation.
I would say for me that falls more under the category of alternative behaviors, which there's a space for that, there's a place for that. even when it comes to just engaging in any type of those somatic activities. I do have a slide where I'm going to talk about that, where we use heat, where we use cold, where we use different sensory experiences. And that can be helpful for somebody on their journey through like the harm reduction on that spectrum. But I think that falls a little bit more under the category of some alternative behaviors.
Thank you. And then we have a couple more. Do we need to move on, or are we okay to keep going?
Let's do one more and then I'll keep going.
Okay. All right. The next one is in the chat. Is there a good analogy to share with those family members that are faced with a child that is cutting? I hear so often that it's so foreign to them that they can't relate. What is the feeling they are seeking when cutting?
I'm going to go back to understanding that the driver for each individual is different, right? So that's going to be central here, because there's not going to be a one size fits all. But when we're trying to share with families and help them understand, one thing that I like to share is, like, imagine this itch. Like, it is this, like, it's a physical sensation, and everything inside of you is telling you, you gotta scratch that. You gotta scratch that itch. And it doesn't matter how much you resist. It doesn't matter how much you tell yourself it's a terrible idea. That itch is there. And sometimes the only way people know to alleviate is to scratch that itch. I hope that that's something that's helpful, because I think that's something that we can relate to, like some of those sensory experiences. The underlying of this, so that's the physical part, but the underlying part of this is that there's also a deeply emotional component to this. It's not just the physical itch, but when we're trying to get somebody to understand why somebody doesn't just stop, they feel like they can't. They're compelled to seek relief in that way. When we're looking at treatment and evidence-based practices, the reality is that we're a bit limited when it comes to NSSI. NSSI has been categorized as being treatment resistant for a long time, but we know that it can cause some pretty severe injuries and some pretty significant harm to those who are struggling with this behavior. In the past, I know that we're working to make a shift here in California, but in the past, the standard response to NSSI has been hospitalization. And it's kind of like, this is scary. I don't know what to do with you. You're not saying that you're going to take your life, but what if you do, right? And so it's some of that fear-based response, but that's not effective either. Like, we know that hospitalizing folks that struggle with NSSI, it doesn't help. There has not really been significant work that identifies efficacy in outcomes when we're trying to reduce NSSI with some of the standard approaches that we utilize. So I want this on one part to be like reassuring to you all that it's not that we are missing something grand out there. The reality is that the information is sparse. But two, I also hope that this is a motivator for people to continue the mission to learn more. One thing that I often hear about is like, well, isn't DBT evidence-based for NSSI? And I have to remind folks that DBT is evidence-based for borderline personality disorder, which, yes, includes NSSI and suicidal behaviors. Like, those are prominent symptoms. But when we have looked at NSSI apart from borderline, the outcomes, it's not that clear. And we know that data that's been gathered, sometimes there's things are all mixed up in there, where people are, well, we're looking at DBT and we're looking at borderline, but we're not separating NSSI. And so it was hard. There's not good data out there. So we need to keep working at this. It's super, super important. I think a lot of, and this is the reality of systems that we work in, that there is a lot of value placed on evidence-based practices, and I agree that it is important, but that can't be the only lens through which we see things, because oftentimes that creates an opportunity for us to miss the people part of the work that we do. So like I mentioned, data is still emerging. Harm reduction is tricky. There's a lot of folks who view harm reduction as risky, both legally and ethically. There's some researchers that are probably like, no way, no how am I ever going to do research on harm reduction because you're asking me to facilitate somebody's harm, and that might feel ethically compromising. But again, it's important that we keep this at the forefront because there's a lot for us to learn. The most information that we have right now does center around DBT, CBT, problem-solving therapy, and emerging on harm reduction. One great thing about what we have emerging on harm reduction is that so much of it has been driven by people with lived experience, even when we're looking at NSSI. And those are probably the most important and the most powerful voices that we should be listening to. When we're looking at harm reduction strategies for NSSI, the first step is training staff on self-harm management. So we need to make sure that we are equipping individuals to identify self-harm, to understand self-harm, and then move into implementing support strategies. And then we need to empower individual choice. We have to collaborate with the individuals that we're working with to really develop alternative coping strategies if that's what they so desire, if that is where they're at, and give them a sense of control and agency. And the last piece is access. So the reality is that there is a lot of folks that don't have access. And so again, this is a systemic thing that we need to have that awareness. Who has access? And how can we improve or increase access for individuals in the roles that we serve in? Foundational to this is a compassionate, non-judgmental approach that focuses on harm reduction rather than elimination. So this is going to go back to where I started. We have to care about the person. We have to care about their suffering. We have to care about their wellness more than we care about stopping the behavior. So there can be endless barriers to treatment, but specifically when we are looking at youth, some of this data is from SAMHSA. I'm just going to read that underlined portion. So specific evidence-based interventions to address suicidal ideation and self-harm behaviors are often underutilized or not available. So this just reinforces that previous slide. Those are maybe some systemic things, but there's also so much stigma still surrounding seeking support, seeking help, especially when somebody is dealing with something like NSSI or chronic suicidal ideation. And I'm going to say this is also on the end of practitioners, of mental health professionals. I have interacted with plenty of clients who have expressed to me that they couldn't find a therapist who would see them because they were too much of a liability. I have been actively working with clients in therapy when their prescribers abruptly discharge them because their suicidal ideation is too much of a liability and they believe they need a higher level of care, aka hospitalization, which sometimes is not the case. There's also practical barriers, right? We need to think about cost, transportation, time, lack of parental support for treatment, resistance or limited readiness and motivation to seek treatment. So when people feel like they do not have acceptable treatment options, they are much less likely to engage or to participate. A lack of culturally responsive treatments insurance limitations. This is one of my pet peeves. It's really frustrating when an insurance carrier is telling us as providers and telling our clients what it is that they need or do not need to get better. Absence of affordable treatment options. I'm not going to call out any specific treatment modalities, but I know that even as a provider, there are some incredible trainings that exist out there that we know are so beneficial for individuals, but they're not even accessible to me as a provider because of the cost, right? And so then when we take that same concept and we look at individuals who are seeking care, we might know that there's something that's going to be really impactful for them, but they can't afford the providers who are trained in those modalities. And then there's the aspect of clinicians also being uncomfortable with their own skill set when it comes to treating youth that are experiencing suicidal thoughts and behaviors, or they haven't necessarily received the most adequate training just yet when it comes to serving this population. I'm toggling between two screens, guys, here. So sometimes it changes on one and not on the other. I'm sorry about that.
Priscilla, I was just wondering if you could take a moment just to, again, clearly define what is NSSI and differentiate between a diagnosis, a mental health diagnosis versus versus NSSI as it is seen as a condition or disorder.
Okay. So NSSI, non-suicidal self-injury, is harm to the physical self, to somebody's physical body that does not have any intention or desire to take their life. That is not the primary drive for engaging in that self-harm behavior. NSSI can occur within the context of mental health disorders. It can occur within the context of mood disorders. It can occur within the context of anxiety disorders. It can occur in the context of personality disorders. It does not have to, it does not always, and it can also be a standalone behavior, action, coping mechanism that folks engage in with or without the mental health diagnosis component. This next slide, this just goes through some of the approaches that have been evaluated a bit. I'm not going to spend too much time on it, but this, again, just information that I would love for you all to come back to and look at, because some of these approaches might be things that are helpful for you as you're working with youth. But I don't want to take too much time because I really want to focus on the harm reduction piece of this. Okay. So we have already gotten a foundational understanding of the heart and the spirit of harm reduction this morning. So I'm hoping to just expand on that a little bit and then help to marry the world of harm reduction and NSSI for us. So when we are looking at harm reduction, it's super, super important to remember that this is a philosophy that we combine with a set of strategies. And the goal here is to reduce the negative consequences or the harm as a result of the behaviors. Harm reduction is never intended, I think, to just focus on like reducing that harmful behavior. That might be a natural outcome of the process, but that's not going to be our primary goal. Another thing to consider as we look at really like what it means to have a fully blossoming continuing of care. Harm reduction isn't going to be the end all be all for everybody when it comes to our intervention approaches, but sometimes it might be. And sometimes it's the only meaningful starting point that we can have when we're coming alongside folks that are in really vulnerable situations. So no matter what, this being a starting point, whether it ends up being the end all be all for somebody or it is one step in the process, it's important for us to remember. When we're looking at this philosophy, it's also important to remember that harm reduction doesn't care about looking appealing or being palatable. That's not the goal. The goal is for our approach to really be grounded in kindness, in compassion, in respecting people. And it's through this lens that we truly meet people where they are. So we say that often, like we're going to meet people where they are. But it's messy to meet people where they are. It is so messy sometimes. But we have to remember that if we keep that lens, that's how we support positive change at a pace that really honors the autonomy of each individual person. This can be tough for us as providers. Sometimes we say like, well, everybody has a right to self-determination. But when that self-determination really bumps up against some of your own values, that can be challenging. And harm reduction has the tendency to really do that for folks when it comes to NSSI especially. And I want you guys to know that, yes, there's the substance use lens. Yes, now we're looking at the self-harm lens, but there's so many other health conditions and challenges that people experience that harm reduction can be super, super helpful for because our goal is to recognize and accept where people are. Our goal is to believe that people are capable of change, to believe that people know what they need, really focusing on that preservation of their health, regardless of the behaviors that they're engaging in, like how can that look for that person? And really also honoring that folks engaging in this challenging or risky behavior, it does not mean that they do not have a right to access care and social services. We really, at the core, need to honor the dignity and humanity of all people. I like to use this slide just to remind you all that we all engage in harm reduction practices all the time. We wear seatbelts. We take medication. When we smoke cigarettes, they have filters in them. We follow the speed limit. We brush our teeth, right? These are all harm reduction practices that we engage in all the time. They're just not as triggering when we talk about as when we talk about substance use or NSSI. So keeping with these same foundational principles, just want you to remember, we're going to be at that foundation of kindness and compassion, of remaining trauma-informed, person-centered, culturally responsive, honoring the dignity and worth of every person. This is going to be really important as we start getting into some of these practical strategies. And I'm doing all of this prep because sometimes it can be hard to hear some of the things that we're going to talk about. I'm going to read you all this quote. This is from somebody with lived experience. I had been coerced into treatment by people who said they're trying to help. These things all re-stimulated the feelings of futility, reawakening the sense of hopelessness, loss of control I experienced when being abused. Without exception, these episodes reinforced my sense of distrust in people and belief that help meant humiliation, loss of control, and loss of dignity. This is a prime example of iatrogenic harm. Right? Iatrogenic harm is the harm that comes from treatment, right? So the harm that comes from helping somebody, right? And so we cannot be naive to the fact that the way that we approach helping people hurts them. And we need to take that into consideration. Now, this doesn't mean that, we throw our hands in the air and we're like, oh, well, it is what it is, and there's nothing for us to do. That's not it at all. But we just have to truly meet people where they are and start understanding behaviors. Get curious. Let's lead with curiosity when we don't know and we don't understand, rather than just focusing on the reactions or the outcomes. Back to that same piece, it depends on what the intention is. I think for some folks, bloodletting is a real spiritual practice. And for others, there's this feeling of relief when they engage in the behavior.
And we actually do have another question in the chat. Thank you, Priscilla. What is the youngest age with whom you've incorporated a harm reduction strategy with?
So I work currently largely with teens and young adults. So my personal experience with engaging in harm reduction strategies has been around 12, 13. And so and that might sound like terrifying to some folks, especially as we're getting ready to go get into this next section. But we're never too young to learn, right? And there are some foundational aspects of harm reduction that's all about teaching and empowering people with knowledge. I think sometimes rather than the practical aspect of what harm reduction with NSSI looks like, the most powerful part of the work that I do with people at this stage is that empowering them with knowledge, because I'm not scared to have the conversation, because I'm not scared to say like, hey, okay, I know that you're engaging in this behavior, and we're gonna talk about that. We're gonna get into all of that, but can we talk about how you can be safer? That in and of itself really disarms young people, and even a 12, 13-year-old can have that conversation. I also just want to honor that not everybody might feel comfortable with the full spectrum of harm reduction. It's something that I think we have to continue to be exposed to and learn about and lean into ourselves. I'm fortunate that my first exposure to harm reduction was about 20 years ago. And so I've had 20 years to learn and get comfortable with this. This might be the first time that some folks are hearing about this. And so it's understandable that you might not be ready to jump off that cliff just yet. But continue to really pour into yourself and learn more about this to get comfortable. I think that we owe this to the people that we serve, especially when we are centering, caring more about their suffering and their wellness.
Thank you so much, Priscilla. And then we have actually, I'm really excited about this question, is if you could define iatrogenic harm.
Yes. So iatrogenic harm, in simplest forms, so this actually has come out of like the medical field, so let's say somebody has to have a surgery, right? And a doctor says, this is medically necessary. This is a medically necessary surgery. We've got to do this so that you can be alive, but you know what? You're never going to be able to walk again. But we have to do the surgery so that you can live. So that is an example of iatrogenic harm. There's iatrogenic harm in the work that we do in the clinical world as well. So when it's specifically like, let's looking at NSSI, right? Like, if we look at the model that has been widely used in the past, which is, well, I think you're unsafe, and so you've got to go to the hospital. And so we have people getting psychiatrically hospitalized, and that experience can be incredibly traumatic. They might be exposed to things or experience things that they never have in their life. So yes, they didn't self-harm for a couple days, but now they're out and they are carrying boatloads of trauma from what that experience was. That's iatrogenic harm. So harm reduction and NSSI. So traditional approaches have really viewed self-harm as something that needs to be controlled or stopped. And one thing that we need to remember is that when we put on that lens, sometimes we end up driving those self-harming behaviors underground, and that inherently makes things a lot more dangerous. When people are hiding what they are doing, when they are concealing what they are doing, we don't have an opportunity to teach or to empower or to share alternatives or to explore with them. That for me, that's when it becomes the most scary. So harm reduction in self-harm approaches really centers that I'm going to keep saying these same things, but that non-judgment and that compassion. Okay, so we don't want you to hide it. We don't want you to conceal it. I want you to tell me. Also, this is like not being afraid to ask questions. When your clients come in and you notice something, sometimes we think maybe it's impolite to inquire about it. I say inquire. You know, you don't have to hit them with that the first moment they walk in the door, but at some point it's okay to say, "Hey, I noticed that there's some fresh cuts on your arm. Can you tell me about that?" We can't be afraid to approach things and ask questions through that lens of being non-judgmental and being compassionate. So something that we will struggle with as providers, and I'm just going to say this globally because I don't want to pick any particular folks apart, but sometimes we don't want to be perceived as though we're condoning clients hurting themselves or that we're giving them ideas of where to cut or what to do. We sometimes hear this with folks that are a little bit afraid or guarded when they're asking about suicidal ideation. Well, if I ask the question, is that not going to give them the idea? Well, they're probably already thinking about it, right? There's going to be some specifics around cutting that I talk about in a couple of slides, because we do want to make sure that we are being sensitive and appropriate to what we're sharing with our clients. So again, don't think that there's like no qualifiers or things that we are not assessing or taking into consideration when we're engaging in harm reduction. We need to really have uncomfortable conversations. Our clients need to know that our discomfort is not the priority. Their wellness is the priority. And there are times when folks will not share things with us because they have a sense that like, oof, I can't tell Priscilla that. She kind of gave me a look, or, I dropped a little bit and her reaction told me that maybe she's afraid of what I'm doing. And so we've got to really deal with our own discomfort. The more that we can be open, the more that we can welcome this in our clients, the better things can be. This is really an opportunity to help them engaging in some alternative practices or in some safer practices. And then just leaning back on that, like we got to get curious. We need to get curious and we need to really aim to understand how NSSI is helping our clients. There's no one size fits all. This first point, I really want you all to hold on to as you work into integrating this into practice. What's safer for one client may be triggering or exacerbating risk and harm in another client. This is a lot more complex than substance use disorder harm reduction strategies, because you have to really learn and think and weigh and use your clinical judgment. And this is why it's so important to ask these tough questions and have this dialogue with our clients. There's no one size fits all. This is why it can be a bit tricky. Learning those questions to ask through those assessments that I shared earlier in the presentation can really help to help you to develop how you expand your clinical judgment, how you make these decisions. I don't want to negate that NSSI is very complex, and that without appropriate understanding, we can perpetuate harm. Right. And so the example that I have here is like cutting implements. So let's say that like a client, we're going to say like, here's your cutting. We're not, this is just an extreme example, okay, but here's your cutting kit. Here's what you're gonna use. Here's a razor, keep that right next to your bed. that might actually perpetuate harm for a client. But if we took the approach of saying, hey, what's safe to use, what's riskier to use, could you maybe keep your things in another room? And that way it gives you some time to prepare, to slow down your process, to assess what you're doing before you actually engage in the behavior. Okay, that's just something to consider. And peer supports are also a critically important part of this process. Very similarly, when we look at 12 steps, the community and the fellowship of those spaces, those relationships, are part of what is so transformative. It is no different. It is no different here. And so we want to make sure that we are cultivating opportunities for peer supports to be integrated. Harm reduction recognizes that self-harm meets a need for those who do it, and a full cessation at any given moment is unrealistic. So we're not in the business of condoning any behavior, right? That's not what we're trying to do. The goal really is for individuals to be linked to treatment services. If that's not us, that we're making sure that we're getting them connected to the care that they need. So some of us might work in settings where we're just doing some basic case management, or we might be just doing some crisis response. Keeping that in mind and you being ready to connect people to the care that they need is super, super important. We are trying to preserve somebody's life and really minimize the risk of serious damage and infection. And so stabilizing, securing, giving the piece that we can in our role, and then making sure that they have the access to what they need. When we're looking at these concrete strategies, it's really important that we keep that lens of empathy, respect, and non-judgment. I know I'm a broken record, but I have to keep saying it because it's going to get progressively more challenging here, okay? So when we're looking at these strategies, gradual reduction for individuals who are not ready to stop or don't have a desire to stop self-harming immediately, this may be the focus for them. Maybe they're looking at reducing that frequency, the severity, and when we're talking about severity, we're looking at like where on their bodies they're harming, what might be riskier, what might be safer, and really through this, encouraging individuals to set achievable goals and track their progress. So continually working towards like healthy alternatives, whatever that looks like for them, but allowing them to see that they're making some changes. One example, when I worked in corrections, one thing that I would do when some of my clients were being released that didn't have any intention of ceasing their substance use, we would plan their drug use. That sounds crazy to some people, but I would say, well, what do you think is reasonable? Is it reasonable that you're going to be using 7 days a week? Or do you want to do something different? And that really allowed them to say, you know what, I think I would really like to work on only using 3 days a week. Great. What 3 days of the week do you think you're going to use? Like, let's plan that out. Let's look at what that looks like. What time of the day, what's going to be safer, what situations, these types of things. So it's bringing that lens to this. So while harm reduction strategies can be helpful, we also need to make sure that they're accompanied with appropriate mental health support and interventions from trained professionals, because self-harm is such a complex issue. If we just equip people with the strategies without also pairing them with the support, we're doing them a disservice. And if we really are trying to help folks move to that next step or to a more stable place in their recovery, or finding their joy or their meaning or their purpose, we've got to pair the strategies with support. So this is that safety planning piece that I mentioned. So collaboratively creating a safety plan with a client is really important. So when we're looking at safety planning, there's specific steps that specific things that we need to talk about, and we need to outline specific steps for them to take when they self-harm or when that urge to self-harm arises. So this can include, this is the piece where I mentioned, this can include alternative coping strategies, right? I have a slide where it's like we're talking about like snapping a rubber band or drawing on yourself or using hot and cold. We can include that in somebody's safety plan. We also need to make sure that we have emergency contact information. So whether that's people that they can reach out to for help in that moment, if their self-harm goes sideways, or if they want to engage in that safety plan before they begin self-harming, that's okay too. And a list of professional supports and resources. Making sure that they have a safe plan in place can really provide individuals with that sense of control and preparedness during those moments. We don't want to create a safety plan right then in the moment. This is something that we do collaboratively with our clients. Sometimes folks have asked me, but do people actually use their safety plans? Yes, they absolutely do. Now most of our clients have phones. And so if we create something together in a session, they snap a picture of what it is that we have written out together. Back in the day, like I would write it on like a little 3x5 card, and I would have clients keep that in their wallet. And I can't tell you how many times people come back and are like, it was so helpful to look at that because in the moment I was too triggered. I was too escalated to remember any of the things that we had talked about. But when I looked at it, it was super helpful. We also need to teach our clients to identify triggers and warning signs. So providers can work with clients to identify their triggers and warning signs that precede self-harm episodes. So as we help folks to increase their self-awareness, individuals can really learn to recognize when they're at heightened risk. And it gives them a chance to be proactive to manage those moments. So it can involve implementing some of the strategies that maybe they're learning in therapy. They can practice mindfulness. They can utilize grounding. They can use some of that distraction if they want that opportunity to help ease or get some relief from what they're experiencing. There's also an emphasis here on self-care strategies. So we have to really emphasize the importance of self-care as a harm reduction strategy. So we really want to encourage our clients to engage in activities that really promote that self-soothing and self-nurturing outside of those moments when they're triggered. This means having that conversation of like, how do you take care of your body just in general? Do you eat? Do you sleep? What habits do you engage in? Do you move your body? What brings you joy? What brings you relaxation? Really amplifying these self-care strategies is an important part of this harm reduction process. And healthy coping skills. So we can really help our clients to build a full repertoire of healthy coping skills to either replace self-harming behaviors or to give them that relief that they're seeking, that comfort that they're seeking. So this can include anything from problem-solving techniques, stress management strategies, emotional regulation skills. This is all of like those clinical skills that we have developed in other spaces that we can bring here so that we're really meshing this together. So again, we have to really stay grounded in that empathy, respect, compassion, and non-judgment, because we can do all of these things. We can say all of these things, but if we're doing it from a place where we are really just trying to mitigate the behavior, it's not going to work. It's not going to work. Our clients know if we pass the sniff tests or not. And so that's got to be central to how we do this work. This is a slide that I mentioned that gives some examples of some alternative behaviors. So we can teach clients various distraction techniques to redirect their focus away from self-harming during these moments of distress. They can engage in deep breathing, progressive muscle relaxation, listening to music, drawing, journaling. Sensory tools are really, really important here. We need to really facilitate our clients having a sensory experience. When I talk about these alternative behaviors, I'm honest. I tell my clients this probably isn't going to feel as good as the self-harm that you engage in, but it's something. So let's see what it does for you. Let's see how that feels for you. But there's a lot of tools out there that we can utilize. There's some particular fidgets, they're like fidget rings. And I have found these really helpful with some of my clients who self-harm. They're like a little pointy, and so it gives them a little bit of that sensation of pain without creating any significant harm. And so again, getting curious and encouraging our clients to get curious, like let's try some different things and see how your body responds to that. I have a 5-pound bag of warheads in my office at all time. Those super sour candies. And so that's something that I use pretty frequently with my clients, whether we're working on NSSI or anxiety or intrusive thoughts. And so it's really cool. I encourage you guys to try this. If you pop one of those suckers in your mouth, like it's kind of hard to pay attention to anything else other than the sensation that you're feeling. And then I tell my clients, if you want to up the ante and increase the sensory experience, put that underneath your tongue. And so just remembering that there's different things that we can introduce and share with them that's going to help them have some of that sensory experience that they really are needing. When we look at safer self-harm as a part of harm reduction strategies, we really need to help clients to identify specifically what their self-harm behaviors are and how we can plot those on a spectrum from safer, unsafe to very safe. And so this requires that honest conversation. Allow them to write these things down and keep that, right? So it's like, do you want to try scratching instead of cutting? Have you done that? How has that worked out for you? Those types of things. And practical things like, do you have an up-to-date tetanus shot? Where do you harm? Where in your home do you harm? What do those spaces look like? Are you alone? Is there somebody there with you? We want to really reinforce that it's helpful even if somebody doesn't need to be in the room with you, but if somebody else home in case something goes wrong, there's help there for you. Are you engaging in these behaviors in a clean environment? Are you using clean and sterile implements? What does that mean? Do we talk about having alcohol pads if somebody is cutting and maybe needs to clean up what they're using? Do we talk about them having some first aid supplies on hand, those types of things, ensuring that they're not sharing any of their implements with anybody. And then talking about, well, when you cut, like, how do we make sure that maybe you take into consideration how long that cut is or how deep that cut is. But then we need to get really into the nitty-gritty of what their self-harm looks like. And again, this is a place where we have to check ourselves because when we're asking these questions, you're human, and so it's okay. It can feel unsettling to have our clients describing these things, but we need to be okay holding that space for them. I mentioned burning on this slide as well. So even them just keeping in mind burning for a shorter amount of time, limiting the area being burned, for burns, being prepared for some of that aftercare, right? So removing the source, running under lukewarm water, those types of things. And also, this is just basic knowledge for us. We don't want to use ice. Ice or ice cold water, that can really increase the harm to tissues when somebody has a burn. How are you guys doing here? Just checking in because I know this is
We have a couple questions since you are speaking to some of the alternative strategies or safer ways to cope and self-harm. Folks are asking what are cold caps as well as what is PMR?
Okay. So PMR is progressive muscle relaxation. So that is when we focus on specific muscles in our body and we do tightening like as hard as we can, and then like completely releasing. So one easy descriptor is like, imagine that you are holding a lemon in your hand and you want to squeeze that lemon as tight as you can. Your goal is to make that lemon explode. So you're squeezing, squeezing tight, tight, tight. And then the alternative to that is like, okay, now release, and imagine that your fingers are spaghetti, your arm is jelly. Completely release and relax those muscles. So we can do a series of progressive muscle relaxation exercises from the top of our head to the bottom of our toes. And so that really allows our bodies to enter a state of ease. And some folks find that helpful. Cold caps, literally what they sound like. They're like little caps, like little beanies. You can toss those in the freezer. Some people have started to use these for like migraines and headaches, but it's literally just coldness on your head. And it's, again, that sensory experience that folks need sometimes. So I mentioned burns. There's also approaches like trying to avoid harming your hands or places that are already burned. Teaching clients that when they harm in areas where they have already harmed, maybe that's more dangerous, or can cause like more deeper sustained injuries. I mentioned this before, but things like keeping cutting or self-harm tools in another room. So they're still accessible, but they don't contribute to that impulse to self-harm. One thing to consider is not removing all self-harm implements, which is like tricky. This is very counterintuitive. So sometimes if we remove all like clean, sterile implements, then we increase the risk that somebody's going to use just something that they can find, right? So a dirty blade to cut, something like that. That's going to be riskier. You know, I've had clients that are like, everything's gone, and so I broke a mirror and I used glass. Well, knowing that glass can cut a lot more deeply with less pressure is important for us to know. Making sure that we're also equipping our clients with having some easily accessible alternatives and visible at all times. I love the idea of things being in their spaces. This is why it's important for us to understand where they self-harm. So it's like, if you're doing this in your car, if you're doing this in your room, how can we have some visual reminders so you don't have to think in that moment and you see it? Like, oh, there's my jar of warheads. Or, you know, there's my script for like, you know, engaging in some progressive muscle relaxation. Or I have this progressive muscle relaxation video from YouTube that's like saved on my phone as one of my favorites. And so I can easily access that. We want to encourage our clients to consider not self-harming while they're under the influence, because when you're under the influence, you have less control over the harm that you're engaging in, and that can equate higher risk. Really being careful about cutting over scars. The additional pressure of cutting over scars means that sometimes they inadvertently end up causing more damage, and that makes things a lot more difficult to heal. I mentioned before them harming if they're at home, like just it'd be great if somebody else was home. They don't need to know what they're doing. They don't need to co-sign on what they're engaging in, but leaving doors open, unlocked in case something happens, that somebody can come help you. That is super important, and that somebody can call for help. And them knowing and understanding, like, who are my safe people? This is a part of that safety planning that I mentioned before. Who are my safe people that I can reach out to if something goes wrong? Okay, this next slide, this is probably the most controversial and difficult to swallow aspect of safer self-harm. And this is when we're talking about anatomical safety. I have to give the disclaimer that this content is not appropriate for all clients who engage in self-injurious behavior. So it is critical that you are adequately assessing your clients, assessing the risk, and that you're using sound clinical judgment. Okay, when we talk about anatomical safety, there are literal charts that exist that will tell clients, cut here, don't cut here. Now, the reason why this is not appropriate for everybody is if you are working with a client who is also struggling through pretty serious suicidal ideation, or they vacillate between just engaging in these self-harming behaviors and these intent feelings of wanting to die, we may be inadvertently equipping them with some information on like, well, if you want to take your life, this is where you need to cut. This is why that assessment and you knowing who you're working with and diving deep into these conversations is so, so important. I did not link any of the anatomical charts here, but these are things that you guys can find. And these charts really show the most safe and the most dangerous places to cut. So things that that people are encouraged to is to avoid cutting on the neck, on the wrists and the groin due to major arteries and blood vessels and tendons that can be harmed in those areas. So again, there's that risk of inadvertent, more severe inadvertent harm that comes up. Also cutting along the direction of muscles and tendons. So for example, lengthwise on the arms to reduce the risk of cutting through tendons and muscles or larger nerves. And really cutting on fleshy parts of the body to reduce the risk of damage to structures underneath. So those fatty parts of us are safer places on the body to harm. All of that information needs to also be followed up with us talking about aftercare, whether that's medical attention or wound care. I mentioned before, self-care practices are a really important part of harm reduction. And so this is a part of that as well, that we want to make sure that they are taking as best care of their bodies as they can after engaging in any of these behaviors. So that might mean we need to get medical attention. I got to call somebody. So we always want them to be prepared to call 911 in case more damage is done than they intended. If they're bleeding, if they're rapidly losing blood, we want them to know, apply pressure to minimize the bleeding and follow any instructions, that you get when you call 911. Now, I haven't had a client that has harmed themselves to the point where they needed to call 911. But I have had clients even who have walked into a session after having engaged in some harm and they have some pretty gnarly wounds, right? And it's important for us to say, hey, that really looks like it needs some medical attention. How can we get you some help? So, maybe you can get some stitches, or maybe that pain can be eased a bit. I encourage people to have a basics first aid kit in your office, in your space. We want to encourage them to also have some type of safety kit or first aid supplies, gauze, bandages, those types of things. We want to teach them that if bleeding occurs, we got to stop cutting and assess what that harm is before they continue, right? And then they can determine at that point, do I need medical attention or am I safe? Making sure that they're using clean and sterile gauze or cloths to protect any wounds or any bleeding that is happening, and then teaching them to monitor their wounds daily, and I talk about this like, let's take care of your body, washing their wounds, keeping them covered if they need to, letting them get air if they need to. This is where we really want to lean into professional wound care specialists and people who do this. We're not giving our clients medical attention. And I always tell them, like, I'm not a doctor. I'm not a medical practitioner. Like, here's what I can share with you, but let's make sure that you're connected to somebody that can teach you about these things. And this leads us into the last slide on strategies. We have to be prepared with referral and linkage options as a part of this aftercare. We need to be aware of what exists in our communities. We need to be aware of what barriers to access exist. And we always want to make sure that we're linking folks into ongoing care. Oftentimes, long-term care is required. And so we want to make sure that we are ready and equipped to do that. But this is just, I want you guys to get the juices flowing, right? So I'm going to read this to you. You meet a 19-year-old client with a history of bipolar 1, OCD, self-harm, and substance use, marijuana, methamphetamine, and alcohol. He presents with symptoms of depression, so he's isolating, hopeless, sense of foreshortened future, is making statements that include, I'm worthless, I'm unlovable. He denies current suicidal ideation. He endorses strong urges to self-harm. He denies that he is engaged in any self-harm. You notice that there is a substantial amount of dried blood on his jeans, as though he has bled through. So my first question, I'm going to read them all the questions, and you guys feel free to jump in with any of these. But what is your assessment of risk based on the information provided? Second question is there anything that you would need to know more about? Third question, what are the options to minimize risk? And lastly, what follow-up referrals would be necessary? I see somebody said my immediate concern would be the amount of bleeding. Great. What did he cut with? Be curious about the dry blood. This is really key. So I based this case study on an actual client, on an actual situation that I encountered. And what I learned when I got curious and asked questions was that this actually wasn't intentional self-harm at all. This client was trying to shave his legs for the very first time ever. And I could have jumped into this spiral of being like, oh my gosh, this is how he's presenting. This is really risky. But I took pause and I led with curiosity, compassionate, empathetic. And I learned like, okay, well, that's actually not what's manifesting. But I think sometimes we're very, very quick to jump into an assumption. Everything else that you all mentioned is great. What is his support system? What has helped him in the past? Definitely like being concerned about the amount of bleeding, all of those things. If this client had said, oh, well, actually, this is what you're seeing, absolutely, we would have jumped into all of that. I know this one was a little tricky in that way, but only because I wanted you guys to really keep at the forefront of your mind what it means to lead with curiosity. These are some final reminders. I'm not going to jump through all of them with you, but this kind of just sums up the core of what has been covered today during our time together. I included a list of literature that you guys can all read. If anybody loves to nerd out in that way, I love to nerd out in that way. And so if anybody wants to read or learn more, there's a couple of sites with literature. And then here on our question slide, there's also a book recommendation that I really encourage you all to look into. It's been super, super helpful and just really transformative for me as I've continued to do this work.
Thank you so much deep gratitude, not only from myself and the team. Most of us working in the field see this, work with it, and sometimes don't know what to do with it. So thank you so much for putting this information out there and having this conversation. And even though it can be uncomfortable or controversial, right? So thank you. I want to close with what must we make sure we don't do with what we've heard today as leaders who bridge harm reduction, mental health, and healing justice. Definitely encourage each and every one of you to stay on for the next session, which will be honoring the voices of lived experience and allyship. This was a pretty heavy topic, so please take care of yourself if you need to.